Welcome to this OncLive News Network presentation, broadcasting live from MJH Studios. Today's discussion will be focused on recent advances in treating follicular lymphoma. I'm your host, Dr. Bruce Cheson, Professor of Medicine, Head of Hematology and Cellular Therapy at the Georgetown University Hospital Lombardi Comprehensive Cancer Center in Washington, D.C. Today I am joined by two of my colleagues and friends who are renowned experts in the treatment of lymphoma.
Hi, I'm Dr. Anas Younes, Chief of Lymphoma Service at Memorial Sloan Kettering Cancer Center, and happy to be here.
And I'm Nathan Fowler, Associate Professor of Medicine at the University of Texas MD Anderson Cancer Center in Houston.
We're going to spend the next 60 minutes talking about an area that has seen significant progress recently, the treatment of follicular lymphoma. We'll discuss how the latest data from clinical trials are shaping the way you will treat your patients. At the end of the program, we will open the discussion to answer questions that were submitted to OncLive in advance from our viewers. Now, what we've all seen since we treat a lot of follicular lymphoma is that not all patients are created equal. They seem to show up with similar clinical features and have remarkably different outcomes. There have been a number of attempts to develop prognostic scores to separate these patients into clinically meaningful groups that we approach differently with regard to our therapy. Have we really accomplished that?
It's tough. I think when patients first present to your clinic, we do the typical things. We do staging and we figure out what the grade of the lymphoma is. And then we often have a kind of a discussion about what are the first steps in managing the patient. As you mentioned, because many patients present differently and they can have this very different outcomes with the same therapy, it's a little bit difficult. So I often do use some of the new scoring systems, Flippy2 and Flippy, and these are systems that look at patients' pre-treatment patient characteristics, things like their age, their stage, LDH, et cetera, and it can kind of give us a sense of how patients might do in the long term. Ultimately, I don't necessarily base treatment decisions on those different scoring systems, but it does kind of give me a kind of a gestalt about how these patients are going to do over the long term.
Anas, what about the more molecular prognostic systems like the M7 Flippy?
Right, so the M7 Flippy system uses 7 gene signature to predict the outcome of patients treated with frontline regimens. Unfortunately, it doesn't guide therapy. It doesn't tell us how to treat these patients, just tell us about long-term outcome. But we don't have a prognostic factor model right now based on genetics or biologic features that would guide therapy at the present time.
Yeah, so we treat our patients based on how we treat our patients, not on any of these scoring systems. But after treatment, something strange happens. You've got two basic groups of patients. You've got those who have an event within 1 year or 2 years or 30 months, and they do great if they don't. And if they do, they do very poorly. How can you approach that observation in management of these patients?
That's tough. And what you're referring to, obviously, Bruce, is this data that has come out fairly recently looking at patients that progress early after frontline therapy. And we now have actually there's several groups that have presented data showing that patients that progress after CHOP, as well as some of the other newer combined chemoimmunotherapy regimens, tend to do worse if they progress early. A lot like the Flippy scoring system and the M7 Flippy, although we have this data, I don't think it's really clear how we're going to use this data. What I mean by that is, although these patients tend to do worse, it's unclear whether changing intervention when they relapse is going to change that outcome, right? So it may be that these patients, unfortunately, have certain biological characteristics which are going to portend a poor prognosis, and that will still be poor even with newer agents. Now, I think all of us hope that that's not the truth. And there are a lot of newer trials coming out where we're looking at using novel agents for these patients that progress early. But at least today, I think if I have a patient who progresses within the first 2 years, I still kind of go through the same decision process, and that means picking another chemotherapy, which is different than their first line.
Well, but you're saying we got to wait 2 years and see what happens.
Right.
We have a number of ways to predict outcome earlier, such as PET scans, such as MRD. Do you use those to judge and guide how you manage your patients?
So MRD first is really not used in clinical practice outside clinical research to guide therapy. So we are incorporating multiple different assays to measure circulating tumor DNA and call it MRD in the setup of different treatment strategies. But we're not acting on it yet. We're just collecting this information. The PET, again, PET is also after the event. You already started therapy, so whether you're talking about interim PET or end of therapy PET, yes, they can tell you how the disease will behave, but you're still not picking up these patients up front. So yes, we'd use PET, and it's a very good tool to tell you what the outcome is going to be, but we need some tools or algorithms or guidelines to pick up these patients up front and offer them different therapy if possible.
There's been an observation by Michel Mignon's coworkers of combining total metabolic tumor volume with the FLIPI2 before treatment. You can separate patients into 3 distinct groups. Is that ready for prime time?
I don't think it's ready yet for prime time. The data need to be confirmed, need to be transferable to an average community oncologist to know how to deal with it, interpret it, and then and use it. Right now, I think it's a great observation. I think it's a good research tool. Whether this will become as part of a standard practice, it's yet to be determined, I think.
Did you want to make any more comments?
I think, I mean, I totally agree with Anas. And one of the problems I have with a lot of the scoring systems, whether that's using M7 FLIPI or total metabolic volume, or the FLIPI score, the API, is that they only predict how a group of patients will do. And if you look at individual patients within that, for example, individual patients that are in the M7 FLIPI, a significant portion of them will actually do great and do great long term. So when I'm faced with talking to a patient about this scoring system, I always like, especially patients that have a poor score, I like to remind them that this is not universal, and some patients will do well even with these scoring systems. And again, why that's relevant is when we're thinking about how to design next line regimens and maybe put patients in different buckets, at least with the scoring systems we have today, because they're not universal, I have a hard time picking treatment or putting patients in a certain trial based upon that score, but based upon the available scoring systems.
Yeah, I think we kind of all agree that that's right now the holy grail is predicting patients up front,
Right.
not groups, but individual patients, and stratifying them based on some sort of biomarker as to what kind of therapy they'd respond to versus another. But we are fortunate in having an increasing number of new treatment options for our patients. One of them is kind of a spin off the old, and that is the new subcutaneous Rituximab. We've been using vitamin R for almost 2 decades now, and it's become something in the drinking water. And now we have the opportunity, instead of the 6 hours down to 90 minutes thing, to do it 6 hours down to 10 minutes. Are you ready to adopt that for your patients?
We have already adopted this for our patients at Memorial, and we started treating patients, I think, this week or last week. So I think it's a great advancement from practical point of view. The science is still the same, the outcome is still the same. But for the patient, I think, and for hospitals and clinics, it cuts down on the time required for giving treatment significantly, which is, I think, is a major improvement.
But what I've heard is that whereas for us and for the patients, that's great. But in the community, perhaps keeping patients in the chair longer is financially more beneficial. Is that something you've heard?
I do know that, I have heard that reimbursement can be related to Infusion Times. I think it's hard to know how this is going to play out. There has been a shift in private practice to move infusion centers to community hospitals, so I think a lot of local doctors are no longer operating their own infusion centers. So I'm not sure, again, how that's going to affect the uptake of subcutaneous Rituximab, but I'm sure we'll see things
Yeah, I think it's a colossal advance for patients. The studies have shown doing quality of life measures that
Yes, I agree.
patients just love it. How is this going to be impacted by the biosimilar rituximabs that are coming out?
So, as you mentioned, there are several generic rituximab biosimilars which will be entering into the market probably in the U.S. within the next 1 to 2 years. And I think that, again, this is pure speculation, but I think that, for example, subcutaneous Rituxan or maybe other non-generic rituximabs will have to adjust their price point because if it's easier for patients and is significantly less expensive, I can't see that you're not going to see a shift in usage more towards generic products.
Yeah, there's a lot of jockeying for costs going on right now as they're moving into this arena.
One thing with the subcutaneous rituximab, there are so many of the new, or I guess novel combinations that use rituximab as a partner. And I'm wondering, how as folks that do clinical research, how do you see subcutaneous rituximab compared to infusion rituximab as a combination with novel agents? And what I'm thinking about obviously is a drug called lenalidomide. There is not a lot of data on subcutaneous rituximab with lenalidomide. If lenalidomide becomes a standard, is this something that people will potentially use in combination with lenalidomide?
It would make life easier for a lot of people.
I don't know.
Yeah, but there are other new drugs out there. The FDA granted accelerated approval for copanlisib or Alicopa for patients with relapsed follicular lymphoma. What do we have in that arena now for third-line therapy for follicular lymphoma?
Not much. So if you look at drugs approved, really not much for that space, with the exception of the oral Pi3 kinase idelalisib, which was approved based on almost in a similar indication. So patients get R-Benda, then R-CHOP, or the other way around. And after that, there's only one agent before this one was approved, which is, as I mentioned, idelalisib, and now copanlisib is approved. People tend to use lenalidomide plus minus rituximab off-label, but by the NCCN guidelines. But once you use these agents, really not much outside clinical research that we use. So I think the addition of copanlisib is a major option that will be offered to patients who don't want or are unwilling to participate in clinical trials or don't have options to participate in clinical trials.
I'm going to make you smile. You forgot Y90 ibertumumab.
I know.
tioxetine.
I did not forget them, but nobody's exactly.
See, I
So
made you smile.
exactly right. Well, no, I mean it's true. That is true. So there are 2 single agents for those who are not old enough, I guess, to remember this. So Bexar and Zevalin, that the radioimmune conjugate that unfortunately, despite the high response rate, they're not used widely anymore because of issues related to administration, toxicity, and so forth. They're good drugs. I mean, they're not used chronically. I mean, they're just like sort of like one-shot deal. But
Day one, day 8.
Exactly right. Yeah, you're
done.
done. Yeah, but it's just vanished.
Right. How does copanlisib differ from idelalisib in its mechanism of action?
So there are several different isoforms of Pi3 kinase. And the idelalisib hits mainly the delta isoform, and the drug copanlisib is a pan-Pi3 kinase inhibitor. It tends to hit alpha and delta isoforms more so than the other isoforms. It also is given IV versus the idelalisib, which is given orally. So these differences, meaning the differences in the isoforms it hits, also lead to a slightly different side effect profile with copanlisib compared to idelalisib.
But what's the rationale for targeting both the alpha and the delta?
So there are, let me back up a little bit. Pi3 kinase is a regulator of multiple cellular processes, everything from survival to chemoresistance to genomic stability. And it looks like alpha probably is involved or is more prevalent in resistant follicular lymphomas, and so maybe hitting alpha is going to be better when you're looking at patients that have progressed after multiple lines of therapy. It may also be involved, as I mentioned, in chemoresistance and involved in cellular signaling within the microenvironment.
The Chronos 1 study was in large part responsible for this accelerated approval. What were the data from that study?
So it's a single-arm phase 2 trial in in a way, you can say double refractory. So patients required at least 2 prior regimens, failed alkylating agents and rituximab, and treated with single agent copanlisib. The response rate is pretty good, close to 60%, I think about 58% response rate. CR rate with these agents usually not high, but that's okay because the PFS is pretty good, about 1 year and sometimes exceeds 1 year. Same thing for duration of response. So as single agent, in the third line space, it looks like probably like rituximab as single agent in the old days. 50% response rate was for rituximab with about 1 year PFS. So it's reasonable.
These are people who already failed
Exactly
rituximab.
exactly right. Yes.
But how do these results compare with IDELA?
Almost the same, actually. It's very comparable compared to idelalisib. But the difference mainly is really the safety profile. That's what the major difference between them.
Yeah, so what's the difference in the safety profile?
Well, we saw with idelalisib, there was a significant portion of patients who developed both acute and late colitis. There were also a couple cases of pneumonitis, and in the some of the registration or randomized studies, there appeared to be a significant signal with regards to actually infections, significant infections. With copanlisib, we see a slightly less or slightly lower incidence of colitis, but we do see transient hyperglycemia and hypertension, which we did not see in the idelalisib studies. Luckily, in most of the cases of hyperglycemia, it resolved. Most of the patients did not require significant intervention. In fact, many times we really don't recommend insulin because the drug will still be on board and patients can develop a delayed hypoglycemia. So again, hypertension, fairly transient, around 2 hours, and hyperglycemia, also transient and not too significant in most patients, lasted around 5 to 8 hours. So again, I think this is probably has to do with the different isoforms. The infectious risk, to be fair, I think it's hard to know yet until we see more data with copanlisib. The infectious risk with idelalisib really didn't come out. We didn't really truly understand it until we ran randomized studies, and that's when we saw, again, an increased risk compared to non-idelalisib arms.
Well, the other issue with IDELA was that the median time to follow up in the GoPal study, which was the major publication, was 6 months.
Sure.
And we didn't see the colitis and all that stuff until after that. The median follow-up in the Kronos study is about the same, if I'm not mistaken. So I think we need longer follow-up to make sure. The publication would suggest that even though you are seeing colitis, you're seeing pneumonitis, you're seeing dermatitis and transaminitis, all the itises, it seems to be, and hopefully is, a lower frequency than the other ones. The schedule of administration, though, as you said, 1 pill twice a day versus day 1, 8, 15, a week off indefinitely. Do you envision that being an issue with patient compliance or something else?
Well, it's a very interesting question. I think compliance, it's hard to know because sometimes having a scheduled visit once a week and you set it up on whatever it is, a Monday during lunch, and you're coming every Monday and it becomes a routine thing, maybe the compliance can actually be better with a drug that's given at the doctor's office on a routine schedule than with oral drugs. And we've seen with many other oral drugs across the spectrum of diseases, I can think of HIV, for example, where unfortunately sometimes in an oral drug that's given daily, there's a lot of missed doses. With regards to the usage of the drug, I think that's going to be hard to know. We've talked earlier about academic medical centers where many patients are coming in from out of town. Clearly, a drug that's given weekly is difficult if you're traveling from Little Rock, Arkansas to New York City to get your drug. It's really pretty much inconceivable that you can make that trip weekly indefinitely. So an oral drug in that kind of setting is clearly easier for patients. How this is going to translate into community practices where patients are not traveling too far, I think is hard to know yet.
Again, I think there's advantages, disadvantages for everything. There's the advantage of having an IV is some patients like to see their physicians once a week. They feel more secure. You're keeping an eye on them because now they're coming every week. You're checking on side effects. You're asking them, do you have cough? Do you have diarrhea? So you can detect toxicities early on and act on it early on. Whereas if you give them like one pills to take home, disappear for 2 months and come back, maybe it's too late because they kept taking it, ignoring the side effects and symptoms, and then they get more into trouble. So yes, from convenience point of view, the IV a little bit more inconvenience. I think from a safety issue, it may actually add some safety value for this drug.
Good point. We've mentioned the word biomarkers a few times here. Are there any biomarkers available that will predict either response or toxicity to this agent?
Unfortunately, none that you can use in clinical practice today. There are some correlative studies performed in the context of the trial that led to the approval. Not surprisingly, that Pi3 kinase activation measured by gene signature, it correlated with the response. So that's not surprising. But we don't have selection biomarkers that you can do up front and say, I'm going to give you now copanlisib because your chances you'll respond 100%, or no, copanlisib is not going to work for you. I'd rather give you something else. We're not there yet.
How far away are we?
I think the company did really extensive biomarker studies, again, in the context of the trial. They could, I think, as I recall, they could not find a clear-cut biomarker that can be translated into, let's say, companion diagnostic or to select patients. So at least in the context of copanlisib, the good news is that it has a good response rate. It's not at 10% you have to select them. It's about 60% response rate. But I'm not so sure this will be the next step in the development of this agent.
Well, that's a good segue. I think the next step into developing these agents are phase 3 clinical trials, and there are a number of them going on with this drug. Chronos 2, 3, and 4. Catchy. Could you review those for us?
So the Chronos 2 study, actually I'm going to pause. These are all in low grades, or these are?
Yeah.
Low grade, yeah.
Okay. Yeah. So make sure I get them right. Ready?
Yeah, if you pick up from
Okay.
the beginning of that answer.
Sure. So the Chronos 2 study is copanlisib versus placebo in relapsed low-grade lymphomas. The Chronos 3 study, getting a little more advanced, is copanlisib plus Rituximab, and the Chronos 4 study is copanlisib with R-CHOP versus R-CHOP alone, and these are all going to be in low-grade lymphomas.
And are there any other studies that you could think of doing that might further inform us about the role of this drug in the context of how we currently treat our patients? I have one thought, and that is we're missing the most commonly used chemotherapy drug here, and that's bendamustine.
Mm-hmm.
Is there a trial that you might design that might answer that question about its contribution?
So one of the Chronos actually included either or R-CHOP or R-Benda, and then for practical reasons, I think and then it switched to R-CHOP because there are very few patients. But I agree with you, it would be good to test it in the context of commonly used regimens like R-bendamustine.
Now, all these studies are on relapsed refractory patients. One thing we learned from the IDEL experience was that toxicities were much worse when the drug was used in younger patients and in less heavily pretreated patients, probably because of more intact immune system. Do we have any data that this drug might be safe in the frontline setting?
None that I'm aware of. I don't know of any frontline studies using this drug. And one of the issues with follicular lymphoma, as we pointed out earlier in our discussion, is that many patients can have very heterogeneous outcomes. In fact, some patients with standard chemoimmunotherapy will probably never relapse, at least not in long-term follow-up.
Not in our lifetime.
Right. So I think one of the issues, and we've had problems with this for quite a long time in follicular, is that moving novel agents into the front line is potentially, I don't want to use the word dangerous, but what you don't want to do is take a drug with unknown side effect profile in that setting and expose them to a group of patients who may be cured with standard therapy.
You used the C word.
I do think
I
that
trained you well.
Yes, I do think there are a percentage of patients, unfortunately today it's still a minority of patients, that probably are cured with frontline chemoimmunotherapy and follicular.
Do you agree?
There are some long-term survivors, as for sure. Maybe cured, I don't know, it's possibly, unless we do this, as you mentioned before, circulating tumor DNA and look for these, it's hard to tell, but there are some long-term. But back to your questions, and I see your concern, but we cannot extrapolate from the idelalisib into the copanlisib because it's given on a weekly basis where you have a peak and then the drug clears. This is not continuous level of a drug in the blood forever. So this is, we have to keep an open mind on this drug may be different in terms of safety. But yes, the trials and upfront has to be monitored very carefully, make sure that this will not happen to otherwise a patient who would, destined to live for a long time. But I think the only way we can improve the cure rate for follicular lymphomas is to improve on the treatment outcome of frontline. So the reason why watch and wait or delay treatment make no difference is because what we have is a lousy treatment. Otherwise, it would have made a difference, right? So unless you improve on the regimen, I think we'll not be able to make an impact on patients' cure.
I totally agree. I think, and all of us have worked on frontline regimens using kind of novel agents in follicular. And truly, I think the way we are going to cure these patients is some combination of novels. But I think, at least in my own world, until we have long-term follow-up of drugs like this, I'm still a little hesitant to move them into the front line.
But we've done that. You and I have both moved Rsquared into the front line. And we did that based on, there wasn't a lot of data. There was our CLGB data at the time, but we both did it. And the results were kind of spectacular. So let's create the scenario here. Based on the data that you've published and Peter Martin from our group has published, the response rates with R² up front are in the range of kind of 95%, with CRs around 80 plus or minus 5. If the relevance trial, which was R² versus R chemo, favors R² with those kind of data, which is unlikely because phase 2 data are never the same in phase 3, but even if they're close, where can we go from there?
I think that, again, going back to cure, although the response rates are very, very high with that regimen and as you mentioned, in multiple phase 2 trials, we still see a percentage of patients that relapse. And we've seen that now with longer follow-up that both Peter and I have presented at the last Lugano meeting. We still see probably, if you're looking at about 4 or 5 years, 30% of patients are still relapsing, 30 to 40%
So
of
beyond
patients.
the magical 2-year mark.
Yeah, the late relapses. So I think that I'm hopeful with the new, with the data that will be coming out from the relevant study that we're going to see a group of patients that are doing better than our chemo. But I think that it's not curative in everyone yet. And so I think we're going to have to focus on increasing the percentage of patients that truly get long-term remission or potentially cure. And it goes back to, I think, what Anas mentioned earlier, newer techniques at surveying very low levels of tumor in patients, whether that's circulating tumor DNA or assays looking at very low levels of progenitor cells, or how we're going to move the field forward. So I agree, the old standard design of looking at a drug in combination or as a single agent using overall response rate and maybe even PFS is probably becoming to an end. And we're going to have to develop newer biomarkers to truly assess which patients are cured or which patients have no more detectable DNA.
Now, a couple of years ago, we all went to these NCI working group committee things. And you and I were follicular, you were probably in Hodgkin's. And the follicular came up with a study design where patients with early relapse were going to be randomized to O-CHOP for obinutuzumab, O-umbralisib or TGR-1202, or O-lenalidomide. And so they're focusing on these early relapse patients and doing a bunch of molecular stuff. Do you think that's the correct approach?
It's a good approach. I mean, it's not a wrong approach. You have to work with what you have, and at that time, that's what we had. Well, that's what we knew. I think there's multiple ways to skin a cat, and this is one of them. And then looking at different regimens and see which one the winner, sort of pick the winner. I forgot the design, whether it was like multi-arm in the same trial. These are separate cohorts. Yeah.
Multi-arm sample.
Right. Yeah. So you can pick the winner and see.
But they're focusing on the early relapse patients.
Well, I mean, that's a good question. So, I mean, is this going to hold? I don't know. I mean, you've seen the data, and now it's coming in from the Rsquared in patients who had early relapse, and they're not doing as bad as we thought. Same thing with copanlisib, even though, patients who had early progression with single agent oral Pi3 Kinase inhibitor, they're not doing as bad as we thought. So, based on what we knew at that time, everybody freaked out that if you progress within 2 years, your survival is impacted. Whether this data is going to hold as we introduce more agents, I don't know.
Yeah, my concern was we're focusing all the national resources on relapse patients and not on where I think.
Yeah, but the readout faster, right? So if you want to test new agents, see what's their potential before you move them up front, the readout is faster for relapse patients. So it wouldn't be wrong to test these agents in relapse setting, but that should not be the end point. The end point should move them up front. I agree with you.
Right. Now, we've all seen multiple presentations of some large studies in follicular lymphoma that may or may not be moving the field forward. The Gallium study. What was the Gallium study and what did we learn from it?
So in the Gallium study, this was a study that was actually presented within the last year, and was, I guess, an update was presented at our recent Lugano meeting, looking at upfront or untreated patients with follicular lymphoma and randomizing them, pretty simple design, 1-to-1, to get rituximab plus chemo versus obinutuzumab plus chemo. And the chemo arms could be either bendamustine, CHOP, or CVP. So it's pretty simple design, basically switching out the monoclonal antibody between the two arms.
Yeah. And what did we learn from that study?
Well, we learned that you can, sort of use obinutuzumab with some of these regimens safely. It may add value in terms of PFS. At the time when the data was presented, there was no difference in overall survival. We learned also that when you combine obinutuzumab with bendamustine and give it as maintenance, there's increased toxicities beyond what we've seen with rituximab. So again, there will be some individual patient that may benefit from this combination, others may not be their best option. So there'll be, I think, choices to use obinutuzumab plus CVP. It wouldn't be wrong. Obinutuzumab plus R-CHOP wouldn't be wrong. I would not use obinutuzumab plus bendamustine. I would use rituximab with bendamustine.
Yeah, that observation, I still haven't really gotten my hands around it, because in the Gallium trial, which I presented at ASH a couple of years ago, it was bendamustine versus bendamustine obinutuzumab in rituximab refractory patients with a survival benefit from the combination arm and no increase in toxicity. So we have multiple studies showing no increase on toxicity from bendamustine and CD20s, including obinutuzumab. So I just don't know what to make of the Gallium trial.
In a way, data doesn't fit true, but also remember that when you treat patients in relapse setting, people tend to tolerate toxicities more than the frontline setting. They may be underreported, I think, and
there were more deaths too.
That's right, in the frontline.
Yeah.
Yes, right. But in the relapse setting, people tend to underreport probably because they expected, they can live with it. In the frontline, I think people tend to watch these patients very carefully and tend to report the toxicity more carefully. But I agree with you. I mean, it's in the relapse setting, it was not alarming. But now that what we know from the frontline setting, I think we have to look back again and see whether maintenance obinutuzumab after bendamustine would be also a reasonable option to every patient. I think some patients will be, but at least you need to watch these patients carefully, make decisions whether you want to continue with obinutuzumab or do something else.
It looked like that most of the excess deaths that we saw with the obinutuzumab plus bendamustine occurred late. Interestingly, it occurred during, as Anas mentioned, occurred during the maintenance arm. And one thing they had done in this study, in several patients, they had monitored their T cell levels after they received bendamustine. And you saw that many patients who received bendamustine, and I think we've all kind of known about this, have a kind of prolonged immunosuppression that continued after they finished treatment into the maintenance arm. So it's unclear. And one other thing is that the excess deaths were seen both with Rituxan and with obinutuzumab during the maintenance following bendamustine. What I find, as you mentioned, is that in other studies, including the BRIGHT study, including the STEEL study, it's even if patients are not monitored, that we didn't see a signal with regards to mortality, excess mortality in the bendamustine arm in those studies. In the Gallium trial, there were more older patients that were on the bendamustine arms. Mm-hmm. Not significant, but there were slightly more patients that were in their 70s and 80s in those arms. Maybe that caused excess deaths. In addition, you can hypothesize that if you knew that patients were going to get bendamustine, they were probably sometimes patients that were less healthy went onto those arms compared to R-CHOP. So there may have been some patient selection in the process, but I don't think you can argue with the T cell numbers. Really, there was definitely immunosuppression that lasted after you stopped bendamustine. So what I take out of that study is that patients who I'm going to give bendamustine plus obinutuzumab or Rituxan, you have to follow them closely. You have to give them prophylaxis if you suspect that you're going to have.
What's your practice, Bruce? Let me ask you. What do you do with this data? How do you use it in your practice?
Well, we have been using either BR or R² up front. And for those patients who didn't get B up front, we're doing the Gallium regimen, BO, in the relapse setting. Of course, we try and put all the patients on clinical trials without chemotherapy, but that's our paradigm.
Right. But once obinutuzumab is expected to be approved for frontline, how would you use it?
I don't plan on using it, not because of this, but because of the Gallium results. That, yes, there was they met their endpoint for PFS, but there was no survival benefit, and the toxicity, no matter what you looked at, was greater with the obinutuzumab. So it just, to me, doesn't seem like enough information to change my paradigm yet. And you?
As I said, I mean, it's, I think, a discussion point. It's not approved yet, so I haven't used it outside the clinical trials yet, but we'll have to learn from the long-term follow-up.
I think that I probably will use it in the front line with bendamustine or CHOP based upon the PFS curves. I agree with overall survival, there's no difference yet, and that's going to take longer time, but it's still, I mean, I think that we have to, at least most of us agree it's a randomized study and they met its primary endpoint. Not that that should always be the trigger, but the primary endpoint of PFS should lead, if you follow these curves out, to a 3-year prolongation in PFS in the obinutuzumab arm, and it's hard for me to argue with.
Then let me throw this at you. Be prepared to duck. Since most of the troublesome adverse effects occurred during maintenance, would you use maintenance?
I would not. Yeah, so
Okay.
that's, I think that, again, this is speculating as it's not FDA approved yet, but if I was going to use it in combination, I probably would not do maintenance.
And again, haven't been a big fan of maintenance to start with, yes. So, but just because the toxicities occurred during maintenance doesn't mean that maintenance is responsible for it. Could be just delayed side effects from induction therapy.
That's possible, definitely.
It might magnify those results. Oh, excuse me, that's the next topic. The Magnify and the Augment trials. One of our favorite regimens?
Yeah, so what Bruce is talking about is there are 2 studies, potential registration studies for lenalidomide, rituximab, or Rsquared in relapsed follicular. The first is the Magnified trial where everybody's getting Rsquared. And then basically the study's looking at maintenance either with rituximab or with Rsquared. And the Augment study is a phase 3 study where patients, one arm is getting, this is again all relapsed follicular, half the patients are getting Rsquared, half the patients are getting rituximab as a single agent. The augment study, we may see some data here within the next 6 to 12 months, depending on how the study is accruing, et cetera. And the magnified study, I think, is still quite a ways out from reading. We saw some preliminary data at the national meetings this year from the magnified trial, but that really was just the results from the induction arm. They looked at basically patients, well, they looked at the overall response. They also looked at patients who were double refractory, that means refractory to an alkylator as well as rituximab, as well as patients in this group that we've been talking about, these patients that progressed within 2 years. And it looked like R-squared in both of those groups had a response rate over 60%. I have a little bit of a problem because these are, again, these are interim results from an ongoing phase 3 trial. It's hard to know, again, how that's going to translate into with regards to PFS when you put patients on different maintenance. It's a subset analysis of a study. It's not part of the primary endpoint. So I take that as again, evidence that the regimen probably does work in a group of patients that are relapsed, but I would not change practice based upon these early results from the magnified trial. And the augment study, there's nothing published yet.
Well, we've been kind of talking about the same drugs over and over again, the same classes of drugs. There are quite a number of other novel agents out there, some of which seem to have promise in follicular lymphoma. Some have less promise than we would like them to, despite their mechanisms of action. And I think it teaches us a lesson that not all B-cell lymphomas should be considered the same. Let's look at ibrutinib, for example. Ibrutinib in follicular lymphoma.
So ibrutinib, the B-cell receptor targeting agent, targeting BTK, it's approved by the FDA for 4 different indications, like CLL, Waldenstrom, marginal zone, and mantle cell lymphomas, right?
And GVH. Yeah.
And GVH, right. For follicular lymphomas, the response rate measured by PR plus CR is not very good. It ranges, depending on the study, 18 to 24%, and for some odd reason, Rituximab refractory patient didn't do well either. But if you look at the waterfall plot and the PFS, actually it's not bad. I mean, the PFS is almost about a year, despite the low response rate. So it's not, didn't generate a lot of excitement, but there seemed to be some benefit from it. The question, how do you position this in this landscape? And I think it's going to be mainly combination strategies. There are trials looking at single agent ibrutinib in patients with follicular lymphomas with PET positive at the end of induction therapy to see if you can convert PET positive to PET negative, whether this will improve PFS. It's a single arm, it's just exploratory. Whether this will become like a space for the drug to be developed, I don't know. But I think it's going to be a combination drug. I don't think it's going to be a single agent drug.
The DAWN study was 20.8, and that was the registration trial and was considered a negative study.
Right.
So I think I agree with you. And we're doing a combination of that plus venetoclax at our institution now.
Yep.
What about venetoclax? It's the same kind of situation here.
Yeah, you would think that a drug targeting BCL2, which is the hallmark mutation of this disease, would have very high responses in follicular. Unfortunately, well, I shouldn't say, it's funny in lymphoma, we get so used to responses of 80, 90% that anything less than 50 we don't pay as much attention to. The drug does have activity in low-grade lymphomas. But
it's not like CLL, it's not like mantle cell.
It's not really been the home run that we thought it might be. So venetoclax, there are, as you mentioned, several combination studies looking at venetoclax plus ibrutinib, venetoclax plus lenalidomide, and venetoclax, I think there's venetoclax plus rituximab in low-grade lymphomas. But I think that drug as a single agent probably will not have a major impact like we've seen with some of the other drugs in low-grade lymphoma.
Other pathways? SIK, JAK,
Well, I think
SIK plus JAK?
Yeah, so I think the one that comes to mind that making a lot of news and traction is that the immune therapies, like checkpoint inhibitors and CAR T cells. Again, unfortunately, there's not much of exciting news coming from follicular lymphomas. There's some activities for checkpoint inhibitors, so they would be like a combination. We did trial in frontline setting with Arbenda, actually combining atezolizumab.
study.
Yes, right, atezolizumab followed by maintenance atezo plus rituximab. So we'll see. And there's a lot of correlative studies looking at minimal residual disease and circulating tumor DNA. But as single agent, it doesn't stand out as good as, let's say, the Hodgkin lymphoma, which was approved for at least the PD-1 targeted agent. CAR T cells, I think it's falling behind. There's not much of publicly reported data about the activity, mainly because people think it's not unmet medical need with the toxicity seen with the CAR T cells. But I think at one point it will come into the picture for maybe fourth relapse or fifth relapse where the outcome is poor. But there's not much data about CAR T cells and follicular lymphomas at the present time.
Yeah, I've had a couple of patients who had failed everything and had bulky disease, and I couldn't think of another drug, and we sent them off for CAR T cell. And the two that I've sent off were in CR 5-6 years later. And it was rather striking.
Right.
And there are studies now looking at it in follicular lymphoma. There are those patients out there. They're not, as we've all talked about, they're the minority, but they are certainly an unmet need.
Right.
Any other drugs out there that are catching your fancy?
So there are,
Like
there are-
maybe EZH2 inhibitors?
yeah,
or-
so there are other targeted drugs that look very attractive. We saw data at this recent meeting in Lugano with EZH2 inhibitor, a drug called tezametostat, which is pretty neat. We know that EZH2 is mutated in about 15 to 20% of patients with follicular lymphoma. And those patients, patients that have EZH2, interestingly, EZH2 mutation at diagnosis tend to do a little better than patients that have wild type EZH2. But it looks like targeting EZH2 with a drug like tezametostat can lead to significant responses. In fact, in the study that was presented by Frank Morchhauser in Lugano, he showed that 92% of patients who had EZH2 mutation and received tezametostat with relapsed follicular responded to therapy.
About 18 patients. Right?
A small number of patients, 18 patients.
Well, now it's
13
updated.
patients.
12 out of 13.
We're updated.
But still, even with a small number, even if you were to argue that response rate dropped to 50% with longer follow-up, it still suggests that using a drug that basically targeted a known mutation in that cancer led to higher responses. And we do have larger cohort of patients that were wild type EZH2, and it was clear that they didn't see that same response rate with patients that did not have the mutation. So unfortunately, it's only in a minority of patients that we see this target.
And it's in follicular and
it's
not
in follicular.
large cell.
But it's a proof of principle, I think, that if you have a mutation that's potentially targetable and you have a drug that works, you can see a response in significant number of patients.
But we don't have long-term follow-up to see how long those responses
That's absolutely
last.
right, yeah.
And that's the problem with a lot of these drugs that we're testing. We just don't, like the checkpoint inhibitors, the follow-up is relatively short, even in Hodgkin's lymphoma. Other drugs that strike your fancy?
Not really.
Yeah, we've studied the SIK-JAK inhibitor,
Yeah.
sertolatinib, and we've treated a few patients and seen some responses, but it's still way too early. We're combining all these things. I mean, it's like the old days. We took all the chemotherapy drugs and did promocytibon makeup even. Now we're doing that with all these targeted drugs, and there are hundreds of studies of doublets and triplets of checkpoint inhibitors and BCR signaling. How do we pick what drugs? How should we pick what drugs? How can we pick what drugs to combine with what drugs? Right now it's totally empiric.
It's very empiric, and unfortunately, because there are no good models to predict toxicity with some of these novel combinations. We've seen many studies in the past 5 years which have been terminated due to excess toxicity.
Several of them were mine.
Yeah, and ours too. I mean, we had
Right.
lenalidomide adalimumab, which was closed just this last month. We saw letters from the FDA going out with combinations of pembrolizumab and lenalidomide in myeloma, which unfortunately there was excess mortality in the combination arms. So today, I think...
And that's had spin-off to the durvalumab.
Correct. Yeah, so it's spinned off to, unfortunately, well, I think it's a good thing to do. It's a safe thing to do. But across the field right now, we're seeing a kind of reevaluation of these combination immunotherapy studies in B-cell malignancies as well as in myeloma until we can really kind of figure out how to predict toxicity and reduce risk for patients.
You've thought about this a lot.
So I think it's a very good point. I think the biggest challenge that we have is how to prioritize, how do we pick as investigators the next combinations, and there's plenty of them floating around. It's a phenomenal number of combinations you can do, not just true novel. There's a Me Too drugs, multiple checkpoint inhibitors plus certain drug. How do you choose which one you want to work with? I think the best idea, and I think it's not easy, is to step back and perform this synergy analysis in independent laboratories and then prioritize which one has the highest chance of being beneficial or synergistic. There's no question that there's many combinations will give you some benefit, but is it the right combination that we want to prioritize? And I think there may be one better than others, and we should seek it then as a group or as a community and say, this is the combination that we want to pursue. Thank you for offering combination C because I want to focus on combination A. Otherwise, it's going to be messy. We'll be doing a lot of trials, competing with each other, and we will not be able to finish these trials because of this competition.
And there's another risk we're running into here. And I remember the old days when you were young and you were...
I was way young. I was way young.
You were way young.
Yeah.
And I was at a cooperative group meeting when I was still at the NIH, and I was listening to them. They'd already done studies with doxorubicin in large cell and epirubicin in
That's
large
right.
cell, and there was another rubicin, and I got up and I said, really, guys, can't you think of anything different? Now we have 5, 6, 7 BTK inhibitors, 4 and 5
Right.
Pi3 inhibitors. We got a swath of anti-CD20s. I don't want us to get in that position again where we're just doing Me Too studies just because the different company will give us their targeted agent rather than the other one.
That's right.
I think it's a risk we run into.
I agree.
In our last few minutes, we have some questions from the audience.
Good.
Some of which I think we got to. Such as, in which patients are we using obinutuzumab in place of rituximab? And I think we got to that. The Gallium data, I think, was supported, and perhaps the Gallium data, we talked about those. Maintenance. Maintenance therapy in follicular lymphoma, you said you're not a maintenance fan.
In patients who only achieve a PR, in other words, they're responding, but we have a little bit of disease left, maybe you have 70% of the tumor burden is gone, I often will add a extended maintenance phase, and that's based upon the PRIMA data showing that there was a higher percentage of patients that could actually achieve CR. Now, I also, and this is not a lot of data for this, I'll just tell Bruce, but I do think that with standard chemoimmunotherapy, there are a group of patients who are at risk for relapsing early. These are the high FLIPI patients who tend to have not the greatest outcomes long term. I sometimes will add rituximab maintenance in a patient who I think is at high risk for early relapse.
Now, what you're doing with maintenance is you're trying to clean up failure in resistant patients. That's essentially what you just said. So
Yes.
why not switch to a different drug at that point? If they got a positive PET, if they are still MRD positive, if we get to some assay that everybody agrees upon, wouldn't that be the time to switch to something with a different mechanism of action instead of more CD20?
Again, it's hard to know because I think I understand the argument. However, again, we saw even without change in the antibody that there was a higher percentage of patients who will achieve CR. In other words, they were still deriving benefit from an anti-CD20 long term. And again, the counter argument is that the patients that did not achieve a remission in the first 6 cycle, or are the patients who have clones that are CD20 resistant or have some resistance mechanism to the chemotherapy that you gave them. And again, switching to an alternate therapy would be the right choice. But I'm not clear, at least in the first line, that those patients have yet declared themselves. I think that, again, there are a group of patients who relapse early and are refractory to the first line or the second line. And those patients definitely need novel strategies. But I'd like to, this is maybe wishful thinking. I think that there maybe still is a
You're
group
still
of
young.
patients who, with maintenance therapy, you can get them in a deep remission and achieve a prolonged disease-free interval.
Okay. Next question, how are you treating older patients in the salvage setting?
It's a good question. So again, not all patients are created equal. Some old patients really fit in playing tennis every other day and traveling, and so those I treat them like anyone else. They get BR if they haven't been exposed to it before. The more frail patients, they usually end up getting single agent, either Rituximab or sometimes in combination of lenalidomide, depending on how much they can tolerate that.
Yep. I think I totally agree. I think it also really depends on the length of their last remission. So many times in patients who are elderly and they have a remission lasting really more than 24 months, I'll just give them CD20 again. And many times you can really get quite a lot of disease control just by re-exposing.
How do you
the
give it
CD20s.
again?
I usually do 4 doses and stop. I don't usually add maintenance. And that's it.
Okay. In the early relapsers, we've already talked about the national trial, doing what we do in the clinical trials. What's the role of transplant in the early relapse
It's
patients?
a good question. I don't know. And again, I don't think people should start jumping into using transplant as standard of care for these patients.
Should not.
Should not outside the clinical trials, because we don't know if this will change the outcome. I think if there's a clinical trial that is looking at the role of transplant in these patients will answer a specific question, I think it's a great idea. But I don't think it's a standard of care. Just because you failed early on, I'm going to intensify therapy and I'll give you more chemo and then high dose therapy because I think this will do you better. I think we may be shooting ourselves in the foot. And then
Do you think this is a setting where CAR T cells may come into play?
I think absolutely. I think that, as Anas mentioned, it's unclear. Well, let me back up a little bit. There are patients who I think we've all seen in practice who become chemorefractory in short order. And unfortunately, despite the activity of most of these novel agents, most of them, as we've talked about, have remission times lasting a year, a year at best. And those patients are still at high risk of dying of their disease. So patients that relapse in short order within the first couple of regimens, novel therapy is really just prolonging remission. It's not curing anybody. The CR rates are very, very low. So in those patients, like Anas, I usually look for a trial that includes stem cell transplant because there is fairly decent data from both allogeneic as well as autologous transplant that durable remissions can be obtained with that type of consolidation. In fact, there's data from, I think this was from consortium data from using transplant in patients that were refractory to 2 lines, and the 10-year remission rate's over 50% in those patients. Again, select group of patients that could tolerate transplant,
And
patients
had
that
very little
responded.
disease.
But I think that in the absence of a novel combination or a clinical trial which is going to change the natural outcome of those patients, I still tend to send them to transplant.
This has been a great discussion. We hope that you found the information to be valuable to your clinical practice. And we welcome your feedback on what we covered here today. Please send your suggestions to onklivennn@onkllive.com. Thank you all for watching the OncLive News Network live broadcast from MJH Studios. And my particular thanks to my good buddies here, Anas and Nathan.
thank
Have
you
a
very
great
much.
day.